First of all, my name's Mark Buchanan. I'm an emergency consultant in Arrow Park Hospital in the Northwest, so just by Liverpool on the Wirral. And I'm also the mental health chair for the Royal College of Emergency Medicine. I've put a link in there just out of interest if anyone wasn't watching parliamentary TV yesterday. The sort of things that we do as a college is trying to make sure that it's better for the patients that we deal with. And one of the things that we all have issues with is obviously the mental health law and the lack of support that we have and the lack of rules we have to try and keep a patient safe. I was invited down to represent the college basically on that with the amendments of the Mental Health Act. So that might be interesting to watch at some other point. It was quite stressful, but it was interesting really. So have a look, and hopefully that will give you a little bit more information about the problems that we have with mental health, and at least hopefully it shows that we're trying our hardest to actually do something about it. So today, first of all, I'd like to thank everyone who's been involved with it, because I know that Barbara, Faye and Gina have been working hard in the background trying to pin down and finalise the programme, and obviously it's been very difficult because of people's working schedules to finalise that. So thank you for bearing with us, and we've got approximately 60 people joining today, which is amazing. And hopefully this may going forward help be the plan that QIPs going forward will have this kind of day to be able to help set and talk about the standards and make QIPs a bit easier than it was last time. So thank you for that. What else? This is going to be recorded, which means that if you enjoy it that much, you can keep on coming back to it. Or more importantly, what we'll do is be able to send it out to people to be able to look at. As we've got QIP leads here and hopefully mental health leads, then from a trust point of view, then it might actually be useful if you're getting your trainees to help you with this, for them to be able to watch it, to again be able to have an idea of what they're actually doing with the paperwork to help go forward. I'm pretty sure that this will probably not take the full 3 hours that we've allocated, but let's see and see how we move forward. Just so I'm aware, is there anything specific anybody wants to get out of this? So I know that we can try and see if we can answer questions. If you want to speak up, or if you want to just put that in the chat, I'm very happy. At any point you want questions answered, we're going to actually have a panel at the end of this, whatever time that is, and it will pick up questions in the chats to be able to answer them at that point, or actually just hold your question to the end. That's also useful. I think that's probably a no. So I think that what we're best doing is just waiting a couple of minutes for the late stragglers that aren't late, because it's only 5 minutes and I know everyone's extremely busy. And then what we'll do is we'll kick off with the team that have set up this QIP for me to start. And I think Barbara's the first person to talk. So we'll just give people another couple of minutes to arrive, and then we'll get started. This is the point I wish we had some lift music.
You could provide that, Mark. Some humming.
I did actually want to be a musician and a singer at one point, and all my friends said I should sing solo that no one else can hear.
Maybe we need like an ED talent. You could provide the talent.
Absolutely. They also said that I also wanted to be a comedian, and they all laughed at me. Oh, the old ones are the best. Right, we've got over 50 attendees, and thank you very much. So I think that let's start then. So Barbara, all over to you.
Thank you. I am just going to get my slides up. Mark, can you tell me when you can see them?
I can see them, and thank you.
Lovely. Okay, so I'm Barbara Cleaver. I'm an emergency medicine consultant. I work at Imperial and have led on mental health for several years at Charing Cross. I'm here to talk to you today about the RCEM Mental Health QIP, and I'm going to give a brief presentation, a bit of a whistle-stop tour, if you like, as to how to get going with the QIP and some of the elements. So first of all, I want to put this slide up, which is how I feel at the moment things are on the shop floor in the departments that I work in. It's complete chaos. You know, we're seeing a rising number of patients with really high acuity mental health issues. There's not enough space, there's not enough staff. Each day feels like we're fighting fire. I'm sure that that's a sentiment that's recognised by probably everybody that's on this call. And sometimes it just feels like things are absolutely out of control. And there's lots of stuff that really feels, as an emergency medicine consultant, that is actually out of our control. We can't control the state of the country, the rising number of mental health attends. We can't control that there's a lack of mental health beds or lack of investment in mental health services over many, many years. And it feels sometimes just really very frustrating. But obviously what we do best in the emergency department is creating a bit of order out of control, out of chaos rather. And I think that if we can frame the mental health QIP around allowing ourselves to set some standards and provide a little bit of order out of the chaos, then we will start winning with the stuff that is within our gift to control. So first of all, I want a big shout out to Nirmal James and all of the RCEM Mental Health QIP team. A phenomenal amount of work has been going on for nearly a year now to make this a reality, and really can't thank colleagues enough for allowing me to participate in joining that team and having some input in it. But really, my hats off to you. You've done the most amazing job in this. Everything is already on the college website. So if you go to information for professionals and into the quality improvement section, you will find, and I've circled it here, details of the mental health QIP. And I think it's important to just stress that this is a QIP and not an audit. Sorry, you're seeing the capacity alert coming up, perhaps. I'll just get rid of that. It's not what I wanted. So you can see here, this is how you find information online on the college website. And the first thing that you'll come across is the organisational standards and a little bit of grading as to whether or not they're kind of fundamental, developmental or aspirational. If you've read the programme today, you'll realise that we've got some bite-sized presentations around those standards, really just to kind of pique your interest if you haven't got them in place already. And I'm just going to spend a little bit of time. I apologise if you can't read this, you might need to zoom in on your phone or on your computer. But the first one is that everybody should have a named mental health lead. And I guess that for many people on the call, that's you. And we're going to hear a little bit about what a typical mental health lead job plan looks like. There should be a policy in place within your department for how we observe patients, particularly those who are high or medium risk for self-harm or suicide. At Imperial, we call that an enhanced observation policy. And actually, we've started to recruit our own RMNs employed by the Acute Trust to help us with this. And we've also recently started to recruit mental health matrons and a lead mental health nurse. And many of you will be far along the journey with that. There's some stuff here around a search policy, and my colleague Jackie from King's is going to be talking a little bit about how that works in her department. I think parallel assessment is probably something that everybody knows about on this call, but Dr. Sachin Patel, a liaison psychiatry consultant who we work with, is going to talk a little bit about what it means and how important it is to get parallel assessment with psych liaison. I'm going to talk a little bit about what the assessment space should ideally look like, and a little bit of a journey that we did at Charing Cross around that. And then we're also going to talk a little bit about rapid tranquilization and introducing droperidol with colleague George Bailey. There's some stuff there around section 136, which we're not really talking about so much today, because there's a lot of information and there's quite a bit of variation nationally around that, with London obviously moving to an online section 136 portal. So we've kind of steered away from that, but there are lots of resources, and you can see within the QIP bundle on the website, there's resources that you can link to the mental health toolkit, which has recently been updated. And one of the things that we're hoping to get out of today is to share the really wonderful resources that we all collectively have with one another, so that we can learn from each other and borrow and steal each other's policy and guidance and adapt it to our own departments. And there'll be a little bit within my section around the plan, which is the Psych Liaison Accreditation Network, and setting the standards. And as you probably are all aware, we are all plan assessed. So there's some clinical standards, which I'm just going to let you read this slide for a second or two. And I think the important thing to say around this slide is that we're trying to really introduce quality into the care of mental health attends in the ED. Really trying to make it safe, robust, but actually provide really good mental health care within the ED that is within our gift to be able to achieve. So you can see there's some stuff here around making sure that there's an appropriate risk assessment and an appropriate mental health triage. There's some stuff here around enhanced observation, so one-to-one observation or intermittent observation for people who require it within the ED, to keep them safe and actually to provide some sort of therapeutic care whilst they are waiting for their comprehensive psych liaison assessment and perhaps further treatment. And what the ED clinician should do when they see that patient. So stuff around physical health assessment, but also kind of that brief assessment, making sure that the ED clinician themselves has captured some stuff around the nature of the self-harm and what's going on for the patient. So how do you get started? Well, one of the first things that you might want to consider is how you create your multidisciplinary team. You might want to include yourself, some trainees, any RMNs that you have in your department, your psych liaison team. You're going to need support from business intelligence or your business manager to pull up some data for you. And that's worth having a good think about as you're starting to register online. And you can register via the RCEM website by clicking on the link. It's recommended that you try to input approximately 5 patients per week, and you could do this either weekly or fortnightly. And as you probably have realised, this is a QIP that's going on for 2 years, which might feel like an exhausting amount of time, but is the right amount of time learning from the previous self-harm QIP that we need to try and get an understanding of how we can improve. And of course, the process measures and the output measures are a little bit difficult and a little bit grey with mental health QIP. And we've left them really rather open for you to develop within your own patch, because actually as mental health leads, you know what's best for your department. Ideally, the total sample size is going to be between 500 to 600 patients. And there'll be the option to review your own individual department performance, if you like, via personal charts, which we'll go into a little later. So once you're into the link, and you can, all of this is within the RCEM QIP package that you should have received, and you can get through the RCEM website. But I just wanted to draw your attention to a few things that we certainly, as the QIP team, had some sort of serious debates on. And this is the first one, is the date and time of the mental health triage. And we're not talking about like a sort of standard initial assessment where you determine, many people might be using Manchester triage system or your own 5-point triage scale where you identify that somebody has presented with self-harm. What we're talking about here is a mental health triage. I'm going to show you a little bit what we do at Imperial on a further slide, but that might include a bit of a risk assessment of that patient, a description of their physical appearance, and you know, more details into the self-harm and how you're going to kind of manage that patient within the department. Now, obviously, the national KPIs are 15 minutes to time to triage, and that's the time that you start the triage or the initial assessment. And based on the previous mental health QIP, we realised that 15 minutes is just an impossible target. It actually takes that amount of time to do a decent mental health triage. And as such, we're aiming for 30 minutes, which we realise is ambitious. I mean, in our own department, often even the time to initial assessment at the moment is about 2 hours. So I realise that's totally ambitious, but it's something to aspire to. And it's something that when you see your data on the run chart, you want to be, you know, making sure that you're going in the right direction as much as possible. The other thing is date and time of ED clinician review. And I mean, in some departments, not necessarily everybody needs a physical health assessment, but ideally it's good for the ED doctors to actually see these patients, or clinicians to see these patients, so that we're capturing within the ED an ED clinician risk assessment, but also a brief line around their physical health. And then I'll just let you have a little read of the rest of this slide. The KPIs on this are within the document, and I think it's important to not get too fixated on those KPIs, but really regularly review internally how you are improving within your own department. So this is an example of what the mental health initial assessment is or might be for your department. You might be on paper, or you might be on an electronic version. We use Cerner Millennium for ours. And so you can see I've just taken a snapshot. You can see I did it yesterday, very late at night. So we've got like a presenting complaint and some additional factors, which are literally radio buttons. And you can see here there's a little bit of a section if they've arrived with the police, for example, whether or not they're on a section 136 or they've come voluntarily with the police. And then you can see that the nursing mental health assessment is here. And for us on Cerner, we click on these radio buttons. And if you click on a number of the high risk things, obviously you're becoming a high risk patient. And there are some actions here around what you might do. And this is how we've risk assessed. I don't think that there's a national standardized way of doing this, but I suppose what we're trying to get out of this is as much information as possible pertaining to the reason why that person has presented with self-harm and the level of risk, particularly around absconsion and perhaps around violence. So that's what ours looks like. And it'd be great to share what other departments are doing around this mental health risk assessment so that we can learn from one another. So then in terms of the clinical data collection, so we think on average it takes probably about 15 to 20 minutes once you've got your data to actually input this into the portal. And there's a real kind of focus in the clinical data around quality. And some of the questions will only appear if you're answering yes. So for example, question 2.1.1, if you've answered that the patient is medium or high risk, it's asking if there is evidence of appropriate observation during the patient, which might be one-to-one observation or every 15 minutes. And you can see here that, you know, it's a little bit grey, all right, and it's going to require people to actually have a good look at the episode of care and the patient notes around this. You'll note here it says that we're not recommending that security staff provide one-to-one observation, that really this is a nursing role. It might be an RMN nursing role or an HCA nursing role, and it doesn't really matter how you provide that within the department, but we're looking for good documentation of continuous observations. And obviously that will be kind of different for each department. So you can see here, there's a bit of a definition of that to help contextualize it. And then I just wanted to cite everybody on the EM clinician documentation. And, you know, for me, I've often said to our A&E trainees that, and other clinicians, that really I'm asking them to focus on the physical health of the patient and allow our site liaison colleagues to comment on the psychiatric episode of care. But I do think it's really important that some key features are captured in a pithy way by the ED team. And I draw your attention to, you know, future thoughts and suicidal plans. Really important to capture that, just in case the patient does manage to abscond, so that you've got an idea of risk around, like, making sure that you're calling the appropriate people to safety net them. Obviously, the physical health assessment is really important, and less of a sort of focus on that timed physical health assessment, but more the robustness of it, and is it a kind of comprehensive physical health assessment. Capacity, mental capacity. Now, this is often something that people try to record when patients arrive in the ED, but of course it's potentially a dynamic assessment. We're fortunate enough to be able to record this fairly quickly electronically, but it'd be really great to see how other departments are doing this. It's a thorny issue, and we're just trying to capture a little bit of data around this, but really important to cite your ED clinicians around making sure they briefly cite whether or not the patient has mental capacity. And then you can see at the bottom here, there's some stuff around safeguarding. I know in our own teams that we're really bad at Imperial at asking adult patients that come in with self-harm whether or not they've got children, or whether or not they themselves are a vulnerable adult and there's a safeguarding issue. Drugs and alcohol, really thorny as well. If you're lucky enough to have alcohol and illicit substance misuse liaison support, this is a great opportunity to record this. It's a great indicator of quality. And of course, so many of our patients have sort of dual diagnoses of mental health and alcohol and drug substance misuse. So really important to try and record that and work towards, if you're not able to get additional support from drug and alcohol liaison services, that might be an area that you really want to work on within your own department. And I wanted to just pop this up here because one of the main features that we talked at a lot when we were pulling this QIP together over the last year is trying to evidence that we are delivering in the emergency department compassionate care. We all know that patients spend an extraordinary amount of time in the ED, particularly those of really high acuity, those that need a Mental Health Act assessment or an admission voluntarily to the Mental Health Trust. And we can't really do anything about the fact that mental health beds are scarce, but what we can do in the ED is deliver compassionate care to people. And I've just put some thoughts that are going through my head around what we can maybe do. And that is, you know, got previous psychiatric medications like quetiapine or other drugs that we might not routinely stock. Are they being stocked in your ED? Are we making sure that patients are getting their regular prescription, if it's appropriate, of mental health medication? Thinking about smoking, often people want to go outside for a cigarette, and you might argue that like, when they're in crisis, it's the worst possible time to ask them to give up smoking. But that in itself presents risk of absconsion, and you know, it is in itself a staff resource, because obviously you're going to want to allow people to go outside, and most of our hospitals are non-smoking sites anyway. So thinking about whether or not you have nicotine replacement therapy. I've put inhalators here. They're not vapes, by the way, they don't create smoke, but they're often quite a good thing because patients can actually sort of mimic actually smoking. Things about leaflets for mental health resources and online resources that people might be able to access on their phones whilst they're in the department. And a really important one is the ability to sleep. And we'll talk more about that when we look at the mental health assessment spaces. But it seems terribly cruel to keep people in an assessment space where they can't actually have the opportunity to sleep, particularly if they're spending more than 24 hours in the ED. All of this is stuff that you'll be able to capture within the online QIP portal. And then evidence of parallel assessment. I won't dwell too much on this because I'm hoping it's going to be really familiar to you, but within the QIP portal, there is a way of documenting whether or not we are engaging with that parallel assessment. Dr. Patel's going to be speaking a little bit more about that later. And there's all sorts of really important reasons why, perhaps even if the patient is not even fit for interview, that you would make a referral to psych liaison. Often our psych liaison teams are able to pull quite a lot of information from their mental health notes, particularly if that patient is known to them, and have a little think about the right approach before they even come down. And of course, fitness for interview is really important here. And if a patient is not fit for interview, it may not be possible for parallel assessment. And I think it's going to be really useful for us to see that data nationally and work out what we can do to help speed up that parallel assessment process. The data presentation will come to you individually, and the QIP team will be able to support you with this. There's some stuff that will be put on SPC charts, on bar charts, on pie charts, as a way to sort of be able to share with your department in a visual way how you're getting on. There's a great little document about understanding SPC charts, which frankly has taken me quite a while to understand. I'm not even sure if I still understand them, but there's a useful document within the QIP section around this. And that's it from me. A whistle-stop tour. I hope that you find using this QIP really useful. I'm going to stop sharing and come down so that you can see me now. And that was a very whistle-stop tour. I mean, there is probably a little bit of time if there's anyone that's got any burning questions now, or we can move on to the next section. Entirely up to you, Mark.
Yeah, I think I'm probably happy for some questions now first before, and obviously we've got the ability to tie everything up at the end. So if anyone does have any questions that they want to ask currently, then please feel free to let us know.
And just on that note, whilst people are thinking of questions, I can see that Nirmal's joined the call, and obviously I don't know if you can get on camera, Nirmal, if you're able to. Don't worry if you're not, but obviously Nirmal's been hugely involved in leading this project and is the real expert in the room. So someone's... yes, I can share the nursing stuff. Sorry, I'm just going to pull the chat up. Bear with me a second. I can see. Yes, we can share the nurse triage slides with you. We are including patients, Kate, who have self-harm, not other presentations. No, this is a self-harm audit. So it's not about patients who've got psychosis or any other mental health. It's entirely for self-harm presentations that have been referred to psych liaison. Dion.
Hello.
Hey.
That was really good. And I mean, one of the things that I actually wrote down is it'd be useful to have sort of meetings like this over the 2 years, because there's so much to learn from others. But that's an aside. I have a few questions, so stop me if you want me to stop, because there's a few of them. Now you'll know between you and other colleagues, you'll know the answer. So this is one that came up with the first one as well that we had. And it's probably, the answer is probably it depends on from site to site, but proof of enhanced observation. So our nursing staff asked us, what does it look like, particularly the 15-minute one? We don't have if you don't have a pro forma that the nurses have created, which takes them additional time, do they do it in their general nursing notes? And again, as you say, departments are chaotic. For them to do that every 15 minutes is probably a challenge. Often what our nurses say is, well, I'm stood at my nurse base. I can see that whole area. Is that good enough? That's not continuous. That's sort of the 15 minutes where they can sort of just look up every now and again and make sure that person is still around. So that's my first one.
I think the question there is that nurse able to keep that patient safe? Because this is what it's all about, rather than the tick box exercise. So I have one nurse who 24/7 sits outside, and I'm going to discuss this in my talk, outside the mental health unit that I have, which are 3 rooms. Now that person doesn't move from there. That's, to me, if they're in my unit, by definition, they are one-to-oneing. Obviously, if that patient is extremely distressed, we might actually need somebody else there. And actually, it may not be one-to-one, it may be several to one in certain situations that I'm sure we've all been in before. Barbara?
Yeah, I mean, I would entirely agree with that. I think, it's really challenging, isn't it? You're not expecting necessarily nursing staff to write every 15 minutes, I'm still observing the patient. I think what you want to see is kind of quality within the notes that the nursing staff are writing. So, this patient is on a one-to-one. Currently, their risk assessment is that they are high risk of absconding. I have, checked in with them and made sure that they're comfortable. I have offered them some food. You want to see within the notes, without being too over prescriptive about it, that there is evidence of ongoing one-to-one observation, if that's deemed the important requirement for that patient, and quality of notes.
So my question is not about one-to-one, it's about the intermittent ones, where, as you say, you don't necessarily want them to enter something every 15 minutes. I think
you want to see some documentation that there is evidence that people are assessing them, and that there's some quality within that RM in enhanced observation.
Okay.
And it's a little bit tricky. It's really tricky because there's not a standardized way of doing it. And some people are on notes, some people are on electronic notes. Yeah. And I think we in each department, you'll see how you might want to improve it.
Yeah. Okay. Can I ask about the nursing mental health triage? So we have one. We also use Cerner. I'd be interested to know two things there. First of all, we don't have so as we know, there is no sort of proven validated risk scoring, and much about mental health triage or mental health risk assessment is clinical opinion. So, we have a senior nurse standing at our triage queue, and they would just indicate on their basis of their clinical opinion and not go through necessarily, the more detail. I quite like that Cerner document. So that's the question is whether that's appropriate enough for them just to say high, medium based on my opinion or low. And then, follow on from that is more specific to your Cerner document there. Did you build it into iView, and does the mental health triage nurse do that little bit?
So I don't know about building it into iView. I got our tech team to basically digitalize a pro forma that we tried for about 6 months. I think in answer to your question, if you feel that the initial assessment nurse in their own documentation who has written whether or not they're high, medium and low risk, and the rationale for that is sufficient, then that's absolutely fine. And you might want to build on that or enhance on that during the quality improvement project. And sorry, I've forgotten what else you asked me.
No, that's it. We already answered the IB one. If I'm allowed.
Can I just come in there? And I'm going to mention something about triage in my talk as well. And that is based on the APEX course, which is an excellent mental health course that's generally in the Northwest, but certainly is in other places as well. In fact, going to Australia next year. So that's that be useful. What I do think from this and seeing in the chat is that lots of people saying we are doing this, we are doing that. That is going to be excellent, because I think that what we all want from this is people to learn from each other and take best practice, and people will have policies, will have performers, and I'm extremely happy to share my children's one that I've got currently, and the adult one I've got currently, because I think that's how we're all going to try and spread things really for the improvement of the patient, which is obviously what we want.
Mark, I've just got one more. Sorry.
Yeah.
Go on.
And this one is particularly interesting. So in the alcohol question, to quote, it says addressed appropriately. So I mean, you know, again, that can be just an address. I appreciate of dealing with the alcohol in some way. So what appropriately means is probably open to interpretation slightly. But more importantly, can this addressed appropriately, when you capture the data, can you refer there to the psych liaison or is this purely the ED clinician one? Because psych liaison will often do a lot more about alcohol.
I think it's both. And I think the difficulty with this is that different departments have got different locally commissioned alcohol and substance misuse liaison services that might be attached to the acute trust or might be attached more to the site liaison. So yes is the answer. I think what you want to make sure is that people that have got a presentation where alcohol and drugs are part of that presentation, that you are addressing it in some way. And that might be simply referral for somebody else to pick that up later after the attendance is over, or might be in-reaching into the department. And I think that that's going to be dependent on local practice.
Okay, thank you. That's me.
So there are some more questions in the chat, which might be actually completed and answered, one in the talks, but two, if not, can we re-ask them at the end? Because hopefully then we've got a little bit more information, and so they are really important, but we just want to make sure that that they're in the right place. And I think that some of them will be answered, to be honest. I'll try and go through them in my talk. Barbara?
Just very quickly to Kate's questions, it's purely patients who their presenting complaint is self-harm. So that, you know, they've cut themselves, they've taken an overdose, but this is a self-harm audit where the patient has been referred to site liaison. So if there's no self-harm, they would not be included in the QIP. That's right.
Yeah. But remember that the changes that we're going to be doing to improve care for the people who have harmed themselves in whichever guise will actually drag up that care for patients who have come in suicidal, extremely anxious, in crisis prior to harming themselves. So it will actually still improve the care for all of this group of patients.